Welcome to the Deep Dive, where we pull out the most crucial clinical insights from the medical guidelines that shape our practice. Today, we're tackling a big one. It's the comprehensive 2023 revisions to the Standards of Care in Diabetes from the American Diabetes Association.
Exactly. And our mission today is pretty clear. We're going to distill this enormous document down into the high-yield, actionable knowledge you really need. Whether you're a medical student, a clinician, or just someone deep in diabetes education, this is for you. We're hitting screening, diagnosis, tech, complications, the whole lifespan.
And there's a huge theme running through all of this, isn't there? It's just that diabetes care is now, more than ever, a team sport. It's not just one doctor anymore. These guidelines are really pushing for a multidisciplinary approach. Dietitians, behavioral health specialists, all working together.
That's right. And that holistic thinking starts right at square one with classification and diagnosis. We still have our main categories, type 1, type 2, and then the specific types like monogenic or cystic fibrosis-related diabetes. But getting that initial label right, it's still a huge challenge.
Tell us a bit more about those diagnostic traps. What are the common mistakes?
Well, the classic one is misdiagnosing type 1 as type 2 in an adult. Someone presents later in life, maybe they're a little overweight, and the assumption is just made. But on the flip side, you also have to remember that type 2 can, in some cases, present with DKA diabetic ketoacidosis. And we see that more often in certain ethnic and racial minority groups, so we can't be rigid.
And getting that classification right is absolutely critical, especially with monogenic diabetes. This isn't just academic, right? It has massive treatment implications.
Oh, massive. I mean, getting it wrong could mean you're putting a patient on insulin for life when they could have just taken a pill. Or maybe they don't need any treatment at all. Take neonatal diabetes from KATP channel mutations. For these individuals, a correct diagnosis can mean switching entirely from insulin injections to just high-dose oral sulfonylureas.
Wow, that's a life-changing difference. From injections to a pill.
It is. And then you have GCK-MODY, where you see this mild, stable hyperglycemia. And the thing is, these individuals generally don't need any glucose-lowering therapy. Their complication risk is very low. So you need genetic testing to confirm it, especially if the picture looks a little atypical or there's a really strong family history.
Okay, let's zoom out to the general population. Who are we screening now for type 2 and pre-diabetes? What's the new benchmark?
The new recommendation is actually very straightforward. Screen all individuals, everyone, starting at age 35. And of course, we still screen earlier for adults who are overweight or obese. That's a BMI over 25 or 23 for Asian Americans if they have at least one other risk factor.
And when we screen, we often lean so heavily on the A1C, that 5.7 to 6.4% range for prediabetes. But it's worth pausing on its limitations, isn't it?
We absolutely have to. It's an indirect measure. A common clinical error is forgetting that anything affecting red blood cell turnover can throw the A1C off. So think about things like severe anemia, a recent blood transfusion, end-stage kidney disease, even pregnancy. All of those can give you a false reading.
So in those cases, you have to be a bit skeptical of the number.
Exactly. But that said, we still rely on the science from the 88AG study, which gives us that strong correlation between A1C and estimated average glucose, or EAG. So as long as those confounding factors aren't in play, it's still a very reliable tool.
Right. So let's shift from diagnosis to prevention and management. The guidelines really double down on the Diabetes Prevention Program, the DPP, as the foundation.
They do. The primary goal is intensive lifestyle modification. That means nutrition, physical activity, and behavioral therapy all rolled into one. The sweet spot for prevention is achieving a weight loss of 7 to 10%. Practically speaking, for most people, that's a 500 to 1,000 calorie deficit per day.
And for those at really high risk, where lifestyle modification might not be enough, metformin is still the go-to pharmacologic option.
Yes, for those high-risk groups, definitely. We're talking about people with a history of gestational diabetes, a BMI of 35 or higher, or an A1C that's already creeping up towards the 6.4% mark.
And speaking of metformin, there's a really important practical alert in the guidelines about its long-term use. We need to be thinking about vitamin B12.
That's right. The risk of B12 deficiency goes up with long-term use. So the guidance is to check levels periodically, especially if your patient develops anemia or peripheral neuropathy symptoms that can easily be mistaken for other diabetes complications.
Good point. Now, moving into managing type 2 in people with obesity, a 5% weight loss is the baseline goal. But the guidelines are pretty aggressive about using medications to get there.
They are. The sources list the 5 FDA-approved long-term options. But the real clinical insight here isn't the list itself, it's the timeline. You have to assess efficacy at 3 months. If the patient hasn't lost at least 5% of their body weight by then, you stop or you switch. No more therapeutic inertia.
A 3-month deadline, that's a strong directive. What about metabolic surgery?
That's still for the highest risk groups. A BMI over 40 or over 35 if other non-surgical methods have failed. It's incredibly effective, but it's not without long-term risks you have to monitor, like vitamin deficiencies or dumping syndrome.
Before we move on, we had to touch on something the guidelines really emphasize this year: social determinants of health.
Yes. You can't separate the clinical from the social. The example they use is food insecurity, which can affect up to 1 in 5 people with diabetes. I mean, if your patient can't afford or access healthy food, all the prescriptions in the world won't matter. The guidelines recommend a simple 2-item screening tool to identify this right in the clinic.
That's so important. Okay, let's talk goals in tech. The general A1C target is still less than 7%. But how do we individualize that?
Individualization is all about balancing benefits and harms. For some patients, a less stringent goal, say less than 8%, is more appropriate. This usually applies if someone has a limited life expectancy, a lot of comorbidities, or, most importantly, a high risk of dangerous hypoglycemia.
And speaking of hypoglycemia, technology is now central to managing that risk. How is continuous glucose monitoring, or CGM, positioned?
It's now the standard of care for most adults with type 1, and it's strongly recommended for young people on multiple daily injections or pumps. The key isn't just prescribing it, it's using it. The recommendation is for near daily use to get the full benefit.
And with CGM, the big metric we're all talking about is time in range, or TIR.
Exactly. That's the percentage of time you spend in that target glucose range, which is 70 to 180 milli-GDL. The goal is to get TIR above 70%. A TIR of 70% correlates really nicely with an A1C of about 7%, but it gives you so much more actionable real-time data.
And let's drop in a quick clinical pearl about CGM interference.
Oh, good one. Yes, you have to remember some drugs can mess with the sensor readings. A key example is hydroxyurea. It can cause falsely high sensor glucose readings. So if you have a patient on that medication, you have to confirm with a fingerstick blood glucose check.
Good to know. And finally, what about preventing a full-blown hypoglycemic crisis?
The guidance is clear. Prescribe glucagon for anyone at increased risk of severe, what we call level 2 or 3 hypoglycemia. It's a safety net. And for patients with hypoglycemia unawareness, those who can't feel their lows coming on, the advice is to temporarily raise their glycemic targets for a few weeks to help restore some of that awareness.
Okay, now we get to the section with some of the biggest shifts.
Yeah.
Managing cardiovascular and renal risk. Let's start with blood pressure. What's the new target?
This is a big one. Confirmed hypertension is still defined as 130 over 80 or higher, but the new treatment target is now less than the 130 over 80 millimilli-Hg. That's a much more aggressive goal than many of us were taught and have been practicing.
That is definitely stricter. What's the recommended medication strategy?
You start with an ACE inhibitor or an ARB, especially if there's also kidney disease or coronary artery disease. And if a patient is on 3 different drugs, including a diuretic, and they're still not at goal, the guidelines say to consider a mineralocorticoid receptor antagonist like spironolactone.
Okay, let's move to lipids. How aggressive are we getting with LDL cholesterol?
Very. For primary prevention in a high-risk person between 40 and 75, you're using a high-intensity statin to get their LDL below 70 milli-GDL. That means aiming for at least a 50% reduction.
And for secondary prevention, someone who's already had a cardiovascular event?
The goal is even tighter. You're aiming for an LDL of less than 55 milli-GDL. And if a high-intensity statin doesn't get you there, you are now expected to add another agent, like ezetimibe or a PCSK9 inhibitor.
We should probably address the elephant in the room with statins. That small, increased risk of developing diabetes.
Absolutely, and the guidelines are very clear on this. Yes, there is a small statistical risk, but the benefit in reducing major cardiovascular events, it just overwhelmingly outweighs that risk. It's not even close. But of course, they remain contraindicated in pregnancy.
Okay, let's get to what might be the single biggest mandate in this entire document, the cardiorenal protection rule.
This is the game changer. It's a non-negotiable for high-risk patients with type 2 diabetes. If your adult patient has established cardiovascular disease, heart failure, or chronic kidney disease, their regimen must include an SGLT2 inhibitor or a GLP-1 receptor agonist with proven cardiovascular benefit.
So wait, let me get this straight. If I have a patient with a history of heart failure, they're on metformin, and their A1C is, say, a perfect 6.5%. You're saying they still need one of these drugs.
Precisely. This recommendation is independent of their baseline A1C. It's independent of their metformin use. These drugs are no longer just for glucose lowering in this population. They are a mandatory standard of care for organ protection.
That completely reframes the treatment algorithm.
Wow. And to round this section out, a quick word on CKD management.
You screen annually with a urine albumin to creatinine ratio and an eGFR. RAAS inhibition with an ACE or ARB is still the cornerstone. But now, you add on an SGLT2 inhibitor and potentially a nonsteroidal MRA like phenardine to slow kidney disease progression and reduce cardiovascular events.
Okay, to wrap up, let's hit on a few specialized settings, starting with older adults, those 65 and up.
The key word here is heterogeneity. These patients are not all the same. You have to screen for geriatric syndromes, polypharmacy, cognitive issues, fall risk, because they all impact diabetes care. And clinically, the goal is often simplification. You want to simplify complex insulin regimens to reduce their burden and, most importantly, their risk of hypoglycemia.
Right, and their A1C targets are on a sliding scale depending on their overall health. Exactly. A healthy, active, older adult might still shoot for an A1C under 7, but for someone with complex health issues, we relax that to under 8. And for someone at the end of life, we pretty much abandon the A1C and just focus on avoiding symptomatic highs and lows.
Okay, what about patients in the hospital?
For non-critically ill patients, the target glucose range is 100 to 180 milli-GDL. You're monitoring before meals or every 4 to 6 hours if they're not eating. And the key here is to use a scheduled insulin regimen, basal, prandial, and correction, not just the sliding scale alone.
Yeah.
And definitely avoid SGLT2 inhibitors in the hospital. Big safety issue.
And our last specialized group, pregnancy. Both GDM and pre-existing diabetes.
The targets here are incredibly tight, fasting under 95 and strict post-meal goals. Insulin is still the preferred medication for GDM.
Right.
We're told metformin and glyburide shouldn't be first line because they do cross the placenta. And one more key point. For anyone with pre-existing type 1 or 2 who becomes pregnant, they should be on low-dose aspirin starting around 12 weeks to help prevent preeclampsia.
Looking back at everything we've covered, the big themes really are about aggressive risk reduction, leveraging technology, and this huge mandate for cardiorenal protection.
Absolutely. It's a shift. Managing diabetes is less about chasing a single A1C number now, and so much more about managing a whole suite of interconnected risks in a way that fits the individual patient.
So to really cement that key takeaway, here's a short clinical exercise for you to think about. You have a 68-year-old patient. He has type 2 diabetes and established cardiovascular disease. He had a heart attack 2 years ago. He presents to you with an A1C of 7.2%, and he's currently on metformin and a sulfonylurea. According to these new standards of care, what is the immediate adjustment you should recommend, and why is that choice prioritized over just, say, increasing the dose of his current meds to get his A1C down?